to Dialogue Across Difference, an event series hosted by the Centre for the Study of Politics and Governance at the University of Minnesota's Humphrey School of Public Affairs. Join us as Centre Director Larry Jacobs and guests engage in conversations across the political and policy spectrum on issues of the day.
Professor Larry Jacobs, and I direct the Center for the Study of Politics and Governance at the Hubert H. Humphrey School of Public Affairs. Thank you for joining us. Before we get going, I want to just give you a heads up that our conversations are geared to including you. And I mean that. You'll see at the bottom of the screen, there's a Q&A button. Click that button, send us your questions. We'll get to as many as possible. And you'll see this is a very important part of the conversation that'll be going on today. Welcome and thank you for joining us for today's program, Health for All. We're delighted to have our special guest today, Elizabeth Fowler, who's the Director and Deputy Administrator of the Centers for Medicare and Medicaid Innovation and the Centers for Medicare and Medicare Services. Ms. Fowler is very well known to those of us in healthcare. She was Executive Vice President for Programs at the Commonwealth Fund. Before that, she was Vice President for Global Health Policy at Johnson & Johnson. Before that, she worked for President Barack Obama on healthcare. I got to know her way back when, about a decade or more ago, when she was Chief Healthcare Counsel to former Senate Finance Committee Chair Max Baucus. And I could go on. Ms. Fowler has a very distinguished record and is widely admired, one of the few admired actually across party lines. She does have a Minnesota connection, which we of course have to acknowledge. She spent 5 years as a health services researcher for Park Nicollet Foundation, and before that, got her law degree at the University of Minnesota. Liz Fowler, thank you so much for joining us.
Thanks so much for the invitation. I try to come back, I guess, virtually in this case, whenever I can.
And I want to recognize my good friend and partner in the series that we've been doing on healthcare, Scott Kiefer, who is Vice President of Public Affairs at Blue Cross Blue Shield in Minnesota. Scott Kiefer, thank you for joining us to provide an orienting welcome.
Yeah, thank you, Larry. Good afternoon, everyone. I'm delighted to be here. And Larry, it's a privilege to be a part of your brand and the partnership that we've had for a number of years. And when I think about your brand and Dialogue Across Difference, I can think of no better person than Liz Fowler. I consider Liz a dear friend and someone who over the years, I had many tough conversations with, going back to when she was working in the Congress and I was still in Washington. But the best thing I can say about Liz, as you said, regardless of sort of your view on some of the issues that Liz has worked on, Liz has one of the just incredible reputations in Washington in the healthcare community and is just well respected. And I think that's really so important, again, to what you've tried to craft, Larry, across your center and what we've tried to set out in the hyperbolic conversations we have about healthcare so we can have dialogue across differences. For those who have had the opportunity to look at the strategic refresh that Liz has put out with her team at the Innovation Center, I think you'll find a roadmap for that discussion and dialogue across difference. And one thing that's really great about this discussion is that the Innovation Center in and of itself, although it was created under the Affordable Care Act, and I think initially there was some partisan tensions there, I think the Innovation Center has proved to be pretty durable and bipartisan in nature. And I would say, as I read through the strategic refresh, some of the issues around reducing the complexity of the financial benchmarks, making those initiatives more scalable, making them all focused and sensitive to the needs that we have around racial and health inequities. Those are some of the same things, ironically, that the Trump administration in the Innovation Center was speaking to. So I think that's the fun part of this conversation. I'll also say I'm delighted that although access to insurance is really important, and as we've said before and discussed in several recent forums, Larry, we have a great story with respect to access. So Liz, one of the things you may not know that's really exciting is the uninsured rate in Minnesota actually fell during the pandemic, which seems really crazy because we were so concerned about people losing their insurance. We see just today that the number of people getting insurance through MNsure, our state-based exchange, is up, and that's a part of it. But really, this isn't the access conversation. We have a good story there, recent history. We have so much work to do, and I think just thinking, Liz, on what I read yesterday, I didn't see your remarks at the US of Care, but your discussion about the need to focus on lowering costs for Medicare beneficiaries, I think is so important. And we think in particular, I know you had some comments about the high cost of drugs and insulin, just really looking forward to the discussion. So thanks everyone for joining us today. Thanks, Liz. We're glad you're here. You're probably glad you're Zooming because I think it's -4 outside right now, but really look forward to the discussion. So welcome everyone.
Well, I don't miss those temperatures. I can tell you that. My car starts whenever I want it to these days, but thanks for having me and thanks for the really warm welcome. I appreciate it.
Thank you very much. Liz Fowler, you know the history of America's work on healthcare pretty well. And if you look at Medicare and Medicaid, which were passed in 1965, one of the themes has been rising costs. Only 10 years after it was passed, you saw Jimmy Carter and then Ronald Reagan making the cost control of national health care expenditures, but also Medicare's surprisingly sharp increase in spending, a top priority. Today, we're looking at an annual increase in 2020 of 3.5%, putting Medicare's expenses at $830 billion. And this fits with the national trend that we're seeing where national health expenditures now account for over 19% of the gross domestic product. And it's coming at a time when the population is aging, which is going to continue to push up the cost of Medicare. It's also at a time when Washington and the national government are expanding access. So this expanding healthcare cost challenge is a real one, and one that we've been wrestling with. Could you situate the work you've been doing in terms of this broader picture of rising and in some cases, really threatening increases in healthcare spending?
Well, I can, and I think some of that goes back to the history of the Innovation Center. Why was the Innovation Center created? And it was really during the debate over expanded coverage. Sorry about the dog in the back. Never fails. Hopefully she doesn't bark. Going back to the time when we were debating the Affordable Care Act, and there were a lot of members of Congress who felt pretty strongly about the need to control healthcare spending and bend the cost curve of health spending, as they termed it. And at the same time, while we were expanding coverage, and when we looked out across the landscape for new ideas, there really weren't a lot of ideas that were ready to be part of federal legislation that could be implemented. And so the Innovation Center was created to really test new models, what was happening out there that maybe were good ideas, and could we test them in Medicare and Medicaid and scale them if need be. And I think now 10 years later, and I saw one of the questions in the chat, like what's the best large scale research proving that value-based care saves money and maintains quality? I'll say, we don't have the answer to that. There is no silver bullet, it turns out. We have 4 models that were certified to be expanded from what the Innovation Center has done from the last 10 years. I wouldn't say they're the most transformational. I mean, they're important models, the home health value-based purchasing, Pioneer ACO, but then also recurrent non-emergent ambulance services and diabetes prevention program, which is important, but it's maybe not in the line of the delivery system reform and the impact that we were seeing. I will say, though, that if you compare the projections for national health expenditures in 2010 with where we ended up 10 years later, it hasn't grown as fast as was predicted back then. So whatever you think is the reason, and maybe it's not the models, or maybe there's been an effect, economic, COVID, you name it, for a number of factors, but there has been a slowing in the rate of growth. I don't think that, I've come to see this as a marathon and not a sprint in terms of what we're trying to achieve. And I also think that we all have something vested in trying to succeed in curbing this growth of health expenditures, because if we can't do it through value and better care and better outcomes, I think what happens because of the solvency debate and other factors is Congress comes in with sort of a meat axe approach and does an across the board cut and says we're going to reduce everybody. So there's a lot riding on the ability to see change and hopefully eventually see savings through what we're trying to do. The solvency date is right around the corner at 2026. So that's what I feel like we have at stake.
Thank you. And you've covered a lot. And for folks who are not healthcare junkies, let me just try to bring you into the conversation a bit more. When Medicare and Medicaid was passed, the dominant model, and until recently still dominant model, was something called fee for service, which meant that each identifiable service that a doctor or hospital provided, they were reimbursed for that. And it created a tremendous incentive to, guess what, provide more services. And some of those services were not needed, some of them actually not helpful or not grounded in science. And it really hurt all of us in terms of the country's pocketbook. So over the last 40 years, since I'd say 1980, there's been a lot of conversation and experimentation with how to transform the way in which providers, again, hospitals and physicians primarily, how they're paid, with the idea if you change the way providers are paid, it's going to change their behavior. And it went from, I'd say initially a focus on consumers, that they could be kind of the discerning shopper. And that turned out not to work. And there was a pushback on that. And more recently, there's been a focus on the providers themselves. And the idea is that providers should be paid for value. That is the healthcare of the patient. And there are a lot of different ways in which that can happen. And the Centers for Medicare and Medicaid Innovation, which Liz Fowler now directs, has been at the forefront of that. And it's really striking, as Scott Kiefer said, the continuity in that thinking about how do we move past fee for service. Liz Fowler, as you know, the Innovation Center, and you've talked about this, batting record, not so great. There are a lot of models, over 50, that have been tried, and only 5 or 6 have actually shown statistically significant savings for Medicare. Why are we still trying to look for this accountable care organization that would reimburse providers for patient health care?
Well, I think if the alternative is unmanaged care, and I use the example of my mother, who's in Medicare, who went to see her, she went to see an orthopedic surgeon for shoulder pain. And the doctor told her she needed a shoulder replacement surgery. And I encouraged her to get a second opinion. That seemed a little extreme for pain. She went to see a second doctor and he said, "You're right, you just need physical therapy." Having someone out there without help managing their care, without help navigating the system to coordinate care for chronic conditions. She also has chronic conditions that need to be monitored. I think it's an approach in traditional Medicare, in fee-for-service Medicare, that can help organize and coordinate better care for patients like my mother, and help her navigate the system, and provide that sort of sounding board and second opinion and navigation. So I think if you look at the Medicare Shared Savings Program, those organizations, and that's part of the Center for Medicare. So we don't run the Shared Savings Program. That is the ACO, sort of the bigger program. Those organizations participating have generated shared savings. They have, if they show that they can coordinate care and save money, they get to share in those savings. And they have generated those savings. And so we think that that sort of care coordination is where we need to go. And Larry, let me say also what we found when I first got in and did sort of a listening tour, like what have we learned over the last 10 years? One of the things that we heard was there were a lot of models, and some of them competed with each other. They collided with each other. We had specialty models and primary care models and ACO models, and they were sometimes competing for the same savings, even within the same health system. So you might have been part of the hip and knee replacement episode of care and part of an ACO. Well, who gets the savings if, for example, my mother sees PT instead of goes for shoulder replacement surgery? And so we're trying to streamline our models and think about how to harmonize them and think about care from a beneficiary perspective rather than from the provider perspective. So we're sort of shifting our focus to what would work for beneficiaries. And that's the strategy that we're trying to implement. And that does call for a greater role for primary care, a greater role for accountable care. In countries that do have lower spending, and I see there's some questions about other countries, and I'm happy to talk about that as well, they do have a more prominent role for primary care in their systems. And we think that that's something we can learn.
So there are a number of different tools that have been talked about at the Innovation Center and by other folks over the years. One of them is risk, that the provider needs to assume some level of risk for the coverage of the patient, that if costs are above some level, then they're going to experience a loss. Or they could experience a gain if they're able to provide high quality care and come under a benchmark of some sort. What role do you think risk plays? Is that the most important tool that you have in your kit?
So that's a really interesting question, and I'd say there's not an easy answer. So for those in the audience that don't follow risk, you know, if a patient is more expensive than you know, than you anticipated according to the benchmark, are you at risk for that extra spending? And we have models that are one-sided risk, where you only get the upside but not the downside. And then there's two-sided risks. And I think that's what you're asking, is about the two-sided risk, if they also bear some responsibility for the losses as well as the savings. And you know, I think it's an open question. And the way that I think about it is that some in our healthcare system are much further ahead, much more advanced in value-based care. They want that risk because they think they can manage it, and they're well-equipped and well-resourced, and they can bear that risk, and they want those opportunities. And we have to make sure that those opportunities are available. At the other end of the spectrum, there are sort of maybe novice providers who haven't made their way into value-based care. And I think there needs to be an on-ramp for them as well. And maybe downside risk is not something that is appropriate. And so I think we have to do both at both ends before we answer the question of whether downside risk is, you know, is a must in order to see the changes we want to see.
We're going to get in a second to the work that you've been doing to address health disparities and social determinants of health. But before we get into that, I just want to tie that into this issue of risks that providers are taking on. If you look at community health centers and other providers for underserved populations, Are those the kind of situations where you think a risk model needs to be, carefully structured and thoughtfully managed?
I mean, I guess the short answer is yes, it needs to be carefully managed, and we need to make sure that we're monitoring impacts, that, looking at the questions, that we're not skimping on care, that appropriate care is available, that patients can continue to see physicians and providers, and not, if you stay in this sort of model, you're not subject to networks. And those are sorts of issues that we track pretty closely.
So another kind of broad topic that comes up in conversations about affordable care organizations and the push towards value-based care, should the government be mandating this? Should it be requiring providers who would rather sit on the sidelines, look for kind of low-hanging fruit, maybe to pick up profits or gains? Or is that something that you see some real downside to?
Larry, you've just hit your head on the other topic that I would say is sort of in this world that, the Innovation Center lives in, that's sort of most controversial. There's the area, the issue of downside risk, and then the issue of mandatory models. I think as we look back at our models, most of them are voluntary. And that may be one reason why we didn't see a lot of savings, because you only go into the model if you think you can make a go of it. And you only stay in the model if it's working for you. And so if you don't think you're going to make more money, you can drop out. We have a couple of mandatory models, not a lot. I think we could be doing more in this area, but those are controversial as well. And, I think we also have to think about safety net providers. You're raising questions about health equity and disparities. Like, do we want to push providers in that don't have the resources, the tools, the capacity, the capital to succeed in these models? I think we need to be really careful about making sure that we're not, setting up some providers to fail. In my mind, I think we do need to get to some sort of mandatory, but I can tell you not everyone in the administration agrees with that. There's a difference of opinion.
Thank you for that candid answer. And just thinking about some of the debates we're having right now about the role of government, I can imagine that there would be significant disagreement outside the administration too, as you move into mandatory models. Let's talk a little bit about what's known as social determinants of health. And this is a very important topic. What we know is that the health of all of us is determined by factors outside of medical care. The stress you have in jobs, your access to nutritious food, your access to affordable housing, and on down the list. And then in addition to that, there are disparities in the medical care that Americans receive, and it tends to correlate with income, race, and ethnicity. What are your thoughts about how this shift towards alternative payment models might be a solution to some of these inequalities in health and healthcare?
Well, I think social determinants of health is part of what we do. I think you mentioned those factors, access to food, housing, transportation, do impact health in a very real way. We've had a model called the Accountable Health Communities model that did test referral and connection to community-based resources that might help patients address some of those social determinants or determinants of health. And I think the way that we're seeing it is that rather than have a standalone model that just looks at social determinants, we should be building in some of what we've learned into our other models, into ACOs, into the Medicare Shared Savings Program, into the other models that we're running. Even, we have an oncology care model. We're thinking about what comes next in oncology. And should those providers also be asking about, nutrition needs, which could directly affect the outcome of their cancer care? And I think we're thinking the answer is yes, that those screenings ought to be more widely used. And so I think there's a whole conversation at the department about how to incorporate social determinants, how far to go down that line. And so absolutely, we're very much interested in that conversation and those solutions.
And like one of the things I like about what you're saying is that there's been a tendency to kind of segment off the health disparities, social determinants conversation with kind of targeted interventions, which have a role. But the issue you're raising and that the department's been, I'd say, working towards is how do we make this holistic? How do we encompass the full set of tools and the payment models so that it's picked up in many places? Let me ask you about some of the strategies, specific strategies that you see as important for addressing why it is that Black, Indigenous, and people of color are receiving healthcare in different ways than whites, and why their health outcomes are so much poorer, inferior. What are some of the tools, specific tools, that you think can help?
To improve care?
Yeah, improve care and kind of address the social determinants issue that you've flagged.
Well, I think we're looking at social determinants in these total cost of care models. And again, like, I think that term is confusing. It's not a capitation necessarily. It is someone is managing the total cost of your care, the total spectrum of your care needs. And I see in the chat or the questions about, all this focus on cost. We are trying to focus more on patients and trying to focus more on the quality metric. And so, but that flexibility to be able to provide those supplemental benefits, those supplemental services, it's very hard to do in a fee-for-service system, which is why in an advanced primary care model, in an ACO model, tends to be the way that we're looking at it, because I think it's more likely to be successful in addressing needs while not raising costs. But I think to some of the questions, we are trying to focus more on care. And I do want to say also that, in the last 10 years, a lot of our models have focused on providers. We spend a lot of time talking about providers, talking to payers, talking to health systems. I think we haven't had the level of input from patients and beneficiaries and consumers that we need. And so we are actively exploring how can we make sure that we're accounting for that patient and consumer voice in what we do. I think this is, it's not, it's something we should have been doing. It's something we do to some extent, but we should be doing more of. For example, when we measure quality, making sure that the metrics we're considering are meaningful to patients, and not just what the provider is looking at for the payment perspective, if that makes sense.
Actually, this issue about collecting data is one of the most basic issues. If you don't, and I'm an academic, I'm all about data. If you're not identifying, collecting, and reporting data, it's very hard to even know about the disparities that do exist. And is that something that's been a priority for you?
The data priority for us has been making our data more available. I think the Innovation Center hasn't made some of its data available to researchers, for example, in the databases that researchers access. So I think, in my mind, when I hear data, I think we need to be making sure that people have access so they can look behind the curtain, look under the hood, and see and be able to do the research that you can do in other parts of Medicare. It's not a direct answer to your question, but that's how I'm thinking about data.
Yeah. One of the ongoing conversations about Medicare was the creation of something known as Medicare Advantage about 20 years ago. And it allows Medicare patients to opt into what is essentially a privately managed alternative from the traditional Medicare program. That's been going on, and it's picked up a good number of Medicare beneficiaries. There's something else that started under the Trump administration that goes by the name of direct contracting entities. And these are privately owned, the privately controlled networks that attempt to generate profit. And there's been some concern about whether or not the department is going to roll that back or how it's going to respond. Members of Congress, former directors of the Centers for Medicare Services and others have kind of weighed in on that. Do you have a reaction to that?
Yeah, because I think I came into this job with a lot of questions about the model, even wrote a blog about it when I was at the Commonwealth Fund before taking over this role, and really had a lot of questions about who was participating and what was the program, the purpose of the program, and have really looked very closely at it. The model is an ACO model. It is the next generation of our ACO portfolio after the next generation model ended at the end of December. This is sort of the next generation. I think the presence of private entities in healthcare is not something new, and it's not unique to CMMI models, the Innovation Center models. Private equity is entering dental care, they're entering behavioral health care, they're entering ambulatory surgical care. So I think if you were worried about new entrants, I think there's, you've probably been reading more than just what's happening in our models. That said, I think there are, would we have done the same model? Would it have looked the same? I think we probably would have done something slightly different, but I think there is some value in this test to try to provide better care to patients, which is at the heart of what we do. Congress tasked us with trying to experiment with payment and delivery system models that provide better care, better outcomes, better value. And I think there's something to learn from it. It is a time-limited, narrow model. It is scheduled to end. We monitor very closely the care that people get. We are looking at whether patients are moving from fee-for-service to Medicare Advantage. We don't think that that's the case. This model is not a gateway. I think that's been one of the criticisms. We monitor patient access. We monitor patient satisfaction. And I am very much aware of some of the criticisms, and we welcome input. I think some of the concerns that have been raised have some merit, but I think some of the concerns have also been not based in fact. But I'm happy to have that discussion, and I'm happy to have that conversation.
Thank you. We've got a question here from Shanasha Whitson, who runs Community Partnership Collaborative 2.0, which is one of the navigators for the Minnesota Health Exchange, where people get, from our basic health plan known as MNsure, and our exchange. And she's got concerns about the fact that Black and Brown people are statistically significantly non-insured. That's been, of course, a durable challenge. And her specific question is, what can grassroots organizations do to organize community around how to get policy change around rising healthcare costs and this gap in access to insurance?
Well, I hope that the access gap is, at least Congress is attempting to close it. I think some of the changes and some of the temporary subsidies and supports that have been included in recent legislation and that are pushed by this administration should help close that gap. I think Minnesota is lucky in that it's one of the states that expanded Medicaid and has one of the lower uninsured rates across the country, but still I think there's more that we can all do. In terms of health costs, I mean, having spent a good number of years on Capitol Hill, I will say members of Congress do listen to constituents. we did a report every week of what people are caring about, what are people writing in about. And as the person who handled healthcare for a senator and earlier a House member, looked at a lot of that incoming and really tried to monitor where things were. And really, it did shape our views, the senator's view of potential policy changes. So I would maintain that people should continue to stay engaged and make sure that they make their voices heard.
Been talking about alternative payment methods as a way to drive lower costs, improve quality of care for patients, and to address the disparities in care. There's another approach, which is rate regulation. And in 1980 or so, Ronald Reagan, the conservative, adopted what was known as a prospective payment system that set rates, and it was expanded from hospitals to physicians. And it's contributed to Medicare having a lower cost per patient than the private insurance world. One of the questions I think relates to this is, why not borrow from what's worked in other countries in looking at rate regulation? Why not, build on that model and not on payment reform itself?
So a couple things. First of all, I spent a summer working for the British National Health Service, and it was really eye-opening. And I also spent a summer working for a German sickness fund, and in a previous job had a global role that that allowed me to learn a lot about a lot of countries' healthcare systems, including, I saw in the conversation, in Taiwan, which is where my mother is from. I think there are obviously countries in the world that do a lot better than we do. But I also think my observation in those travels is that a country's healthcare system is a reflection of their culture. And I think one thing that I would say is that Americans like having choice. Now, some in the audience might disagree with that, but the ability to go see any doctor, the ability to go see any specialist that they want without having to go through any sort of gateway. I also think in terms of the regulated pricing, we do have regulated pricing in Medicare, and the challenge has been you might regulate prices, but you're not regulating volume. And so just because you control the prices doesn't mean that people can't go and get care that may not be necessary. In England, when you go to see a doctor and they say you don't need an MRI, and they're very closely tracking those capped global payments, the patient says, okay, I won't get an MRI. I think here in this country, when someone says you don't need something, you go find another doctor because you're pretty sure you read it on WebMD and you think it might be beneficial and you want to have that access. And I think there is something unique about the American system that is a reflection of, I think, our interest in making sure that we continue to have that access and that choice. I don't think it's a good thing. I think if we were starting from scratch, would we have a single payer system? I think that we would, but we're not starting from scratch. And I think what we would have to give up for some of those systems is maybe more than some people would be willing to sacrifice. And I know that's not a great answer for some and probably will get me in trouble, but that's my observation from working on these issues and traveling and looking at US health policy for a number of years.
Interesting, the recent experience with the new Alzheimer drug that came on the market. We had the FDA approve it. It was controversial because of somewhat limited scientific data. And then we had Medicare recently come out and say that it would only pay for the use of this new Alzheimer's drug if it was directed at individuals in approved clinical trials. Is that an example of the government stepping in and steering the choice of consumers and saying, we're not going to pay for that if it's kind of a choice that you're making?
So I think that decision, and it's a proposed rule, so it's open for comment for 30 days. So if there's disagreement about that proposed rule, now's the time to weigh in. From the CMS perspective, we think it was made based on evidence and based on the science, and based on the potential value to patients, countering the, and also considering, potential side effects.
There's a question here from one of our really involved health policy people and a doctor, Jim Hart. Do you worry that the shared savings models run the risk of underserving patients?
Well, I think that's why we're trying to monitor quality. We're trying to monitor access. We have a lot of pieces in place to make sure that that's not happening. And I think the goal is better outcomes. If we thought that something else was happening and there was a risk to patients, I think that we would be able to see that in the data that we're collecting and analyzing.
Could you give Jim and others an example of specifically what you mean? You're collecting data, you're monitoring. Is there something that stands out, recently, but also in the past, where you could say, hey, this is the kind of thing we don't want to have happen, and we would intervene?
I think, a recent example, I can't think of one that from our specific model, but we do look at access to care. For example, is the level of care being provided to a population about what we would expect it to be compared to for example, a control group or a similarly situated group that isn't part of the model? Do we see, and is that care, what we would consider to be necessary care that could impact health and outcomes? So that's the sort of metrics we're looking at.
I had a number of questions that tie in with community partnerships and community-based efforts to improve care and coverage. Here's one from Joelle Huft. He says, when it comes to addressing social determinants of health, can you talk about partnerships with community-based partners that seem especially promising?
Well, I think we have learned from the accountable health communities model that did require that referral to community-based organizations. I think one challenge has been making sure there's the link between the providers and the community-based resources. And also, I think another model that we have is the diabetes prevention program that enrolls community-based providers. I think that is not always a smooth relationship. The organizations don't necessarily, they're not used to billing Medicare or being paid by Medicare. And so I think we need to do a better job of thinking how to make that relationship and those transactions, I think maybe more simple and more friction-free, if you will.
There's been conversations in Minnesota and nationally about making the price of healthcare transparent or more transparent. And the idea is that this would empower patients / consumers to choose better options for their care. That is maybe less expensive, but equally effective or more effective opportunities. Ed Sheehy wonders, what is the role of price transparency in helping consumers choose more cost-effective care?
I think transparency is actually pretty important. I'm not sure that as a consumer that I would do research if I needed knee surgery and go out and find the cheapest provider, especially since they may or may not be a network. They may or may not, my cost sharing may or may not be reflected in that overall price. If it's urgent care, I think it's unlikely that someone's going to look for a lower cost provider in the case of urgent care. But I think it can play a role in demonstrating how much variation there is in the cost of healthcare across the country. When you see threefold, fivefold, sevenfold difference in basic procedures, I think that's something that's, an indication that something's not working in the system. So I think that price transparency is an important element of driving change, but I don't know that it's that useful in terms of driving consumer or patient behavior.
So I think this is a really interesting observation as part of this shift of the last 4 decades, which started with, Wayne Enthoven, who was an economist at Stanford, arguing that it was really, we needed to empower consumers as discerning shoppers. And after, I don't know, some decades of that not really working out, there's now been this shift, and this is what you've been talking about in terms of accountable care organizations and other ways to organize and coordinate care. So the focus is on the providers and not relying on consumers who could be in a really vulnerable position as someone who's sick, who's not going to be able to go out shopping like they're looking for a car. They need care. And the point that I think you've been making, and jump in here, is we need to be relying on models that put the providers, the hospital doctors, in the position of making reasonable decisions that improve the outcomes for patients.
So I think that's right. I think that variation, though, is an important indicator. Maybe not for patients, but it is an important indicator where maybe it's the ACO, for example, that can look across and look at that data and that information and think about it in making referrals. If you look at some of the models, the bundle payment models that the Innovation Center led, and this was before my time, but a lot of those savings were trying to look for those areas with the greatest variation and squeeze out that variation in cost. If one provider is doing it at the same level of quality, but for half of the cost, that's where you're going to focus your attention and refer your patients if you want to generate those shared savings. And so it's those opportunities to look for huge price variation that represent opportunities to think about scaling and reducing costs and scaling models.
Things that I've observed both in Minnesota and around the country is the effort at transparency has been very difficult. And part of it is methodology and what is appropriate data that consumers should be relying on. And the other part, frankly, is that some of the providers aren't eager for consumers to be, making choices based on cost and quality. I agree with you that there have been spots and opportunities, but I'm also just struck by the challenges and the barriers and so your focus on the provider side of it seems to me to be, more promising, even though, it's the progress has been incremental and you've got a whole lot of providers sitting on the sidelines. The number of ACOs has stagnated or maybe even declined over the last 5 years. I mean, there's a lot of work ahead, but it seems to be more promising than, relying on this lone individual going into healthcare and saying, oh yeah, I'm going to ignore my doctor and make this choice.
Yeah. And I think someone said it well in the chat, that it's necessary, but not sufficient. So, yeah.
This kind of is a related question. Is value-based care looked at differently when it involves an individual making a choice about a chronic condition that requires care? For instance, a surgery or a drug may not require the patient to have as much self-management strategies.
I think that's where we're hoping physicians can help navigate. I think managing chronic conditions and managing multiple chronic conditions is an area where, we've We've looked at models. We think there's a lot of promise. We're trying to figure out what the best approach is to help manage care. What is the best model for very seriously ill or high cost or high need beneficiaries? And we've had a couple of different approaches to testing that. We pulled one back recently, the seriously ill population part of the primary care first model, because we couldn't make the mechanics of it work. But that is sort of the, if we can help solve that, I think we've made a contribution, but it's a hard nut to crack.
There's been a very long debate about whether health is a function of our personal health decisions versus the larger environment, society we live in. Question from Cheryl Bailey. Are Americans in poorer health in similar countries in part because of our weight, sedentary lifestyle, alcohol and tobacco use, and the consumption of processed foods? What can government do to encourage better health habits? Would that produce better cost control and better outcomes?
I mean, it's a good question, and that question came up during the Affordable Care Act, and there was a very strong push for more wellness, more sort of self-care approaches. I think one element of one policy in the legislation let employers put a certain amount of premium dollars towards wellness programs and participation in wellness programs. And the exchanges or the marketplaces, the premiums there can vary by tobacco use. Some argued we should let premiums vary by other health factors or health conditions, but I think at some point it looks like you're just underwriting, and it looks like you're letting insurance companies write policies and charge sick people more. So where do you draw that line between encouraging better behavior but not punishing people for inherent underlying health issues? So I think that's probably an ongoing debate. We probably need to do more in this country. We could do more in food labeling. We could do more in nutrition labeling. That was something else the ACA tried to do, was provide calorie counts and nutritional information at restaurants at certain above a certain size. They've got to provide that information. That was one attempt to try to get people to be more mindful of calorie consumption and nutrition. I think that works to some level, but it's probably not the full answer.
Question from Hazel Tanner. Have you considered using community health workers to assist patients navigate the system and address social determinants of health?
I think we haven't done a lot of that, but I think our administrator, Chiquita Brooks-LaSure, has expressed an interest in trying to find more ways of engaging community health workers and community-based organizations. I think she sees a lot of promise in community-based care. So that's certainly something that we're looking at based on her strong interest.
Got a question. You and I first started to interact back when you were working for Senator Baucus. I was writing a book on healthcare, and you were one of the key people in the Senate working with the White House. And so you have a deep knowledge of the Affordable Care Act and its construction. And you know about the compromises. I'm curious, looking back 20 years, do you think the Affordable Care Act has made significant mistakes?
So I think, the legislative process is an imperfect process. And in this case, it was definitely an imperfect process. You had a Senate bill, you had a House bill, and somewhere along the line, we lost our 60th vote in the Senate to bring the bill back from conference. And so what ended up passing was the Senate bill with some changes through reconciliation, a process that allowed us to make some corrections without the 60 vote hurdle. So that process was necessarily, I think, imperfect, just the way to get the bill passed. I think passing legislation of that size and that complexity is like threading a needle. to get the votes right, the bill, the messaging right, the language right, the score right, the Congressional Budget Office that, has to give us the numbers, the impact. But I will say it's made a huge difference for millions of people in expanding health coverage. It's, obviously been impacted by the Supreme Court decision that made Medicaid expansion optional rather than, as the statute envisioned it, more of a compelled choice for states. And that's impacted, the ability to reach more people, but it has had a huge impact. And we get stories every day of people who feel like their lives have been changed and even saved by the coverage that they've received that they wouldn't have otherwise had.
If somehow the 2022 Liz Fowler could beam back to 2009, what would be the one or two things you might say, here's something we're not paying enough attention to that we should be, it'll make a big difference in 10 years or 15 years?
I mean, I think we did the best with what we had at the time. And I think people don't realize how hard that legislation was to get passed at the time. I think maybe we would have moved faster. I say that as someone who worked for the last committee to mark up the legislation, and we were the ones holding back, the timeline. So, but I think if we would have moved faster and been able to make some of the changes that we were looking at making in conference, maybe it would have been, a different bill, but not that much different than I think what ended up passing.
Criticisms has been that the Affordable Care Act wasn't that affordable, that more money should have been put in for the deductibles. It should have been more, these cliffs. If you're poor, it's more generous than if you're middle class. Do you think that was an area where, in hindsight, if you were there with 2022 knowledge in 2009, something could have been done, or was it just, that $1 trillion kind of limit just put a brake on really going much further?
I mean, look at the Congress now that's trying to pass. I mean, I think you don't realize, that when a member says, I'm not going to vote for anything above this amount, and you're a staffer working on it, you're not looking at, of course, could have been more generous, could have been more, more subsidies, less cliffs. I think we did the best we could with what we had on the table and with the votes that we had, which now seems like a lot more votes than we've got today. So.
Yeah, so these issues were very much in conversation. There was an understanding that being, providing more funding for the subsidies and for extend them higher up the income ladder, that was understood, the consequences of that. It wasn't like, oops, we forgot about that.
I think, I'm not sure we, in terms of the cliff, the 400% cliff, I think, yeah, we wouldn't have had a cliff. I mean, I think if we would have had more funding, we could have had no cliff. We could have provided, some level of funding across the income spectrum. And yeah, any policy you have when you have a cliff is going to create these sort of problems. But again, hindsight is always 20/20, and I think the bill has made a tremendous amount of difference for a lot of people.
I've got a inside the Beltway question for you. Susan Page is coming next week, talk about her book on Speaker Pelosi. And one of the things that Susan says in the book, and others have said this, is that Pelosi was really the hero of the Affordable Care Act, that she stepped in at key moments, she pressured Obama at key moments. Do you think maybe she doesn't get the credit she deserves for the Affordable Care Act and how it turned out?
I absolutely think she deserves a tremendous amount of credit, and so does Senator Reid in the Senate. Having watched them, having watched real leadership try to maneuver and get something passed that they really believed in, despite every obstacle, despite every difficulty, despite every CBO score that comes back that's not what you wanted it to be, despite, you know, the external environment, the pressures from all sides, do more, do less, don't do this, do that. She is an incredible leader. I was really privileged to be able to have that seat and watch that process, as was our administrator, who was working on the House side at the time in that environment in the House, and probably would have more to say about that.
I have several folks here who share what I want to say, which is thank you for this incredible information. Liz Fowler, you are a really important and rare voice in Washington in our health policy debates. I want to thank you very much for joining us and for this terrific conversation.
Well, thanks a lot for the opportunity. And look, I know there's disagreements out there, and I know we could always do more. And I meant it when I said that we are interested in hearing from folks. So that's always been the case. As a public servant, that is part of my job, is to listen and make sure that we're reflecting what we're hearing. So I appreciate the chat, the questions, and the conversation. So thanks, Larry.
Thank you very much. I know that Liz Fowler, you may have to run off to your next meeting, but before I sign off, I want to just give a heads up for some of our upcoming programs. As I just mentioned, we've got a terrific conversation next week, Tuesday, January 25th. We've got a conversation at noon with Susan Page, who's a USA Today Washington Bureau Chief, on her book, Madam Speaker. It's about Nancy Pelosi. It is a very interesting book. It really takes you inside Speaker Pelosi. You may be a conservative and not like Pelosi, but this is something you can learn from, because she is admired across the aisle as frankly tough and strategic and quite smart about how to get things done in Washington. February 3rd, we've got a terrific conversation that we're going to be part of, and we're eager to promote. It's called "Why Has the Unequal Economic Status of Black Americans Persisted into the 21st Century?" Our special guest is Glenn Larry, who is the professor at Brown University, host of The Glenn Show, and is a well-known conservative commentator, with often talking about critically the traditional civil rights movement. I have a lot of admiration for Glenn Larry. Glad he's going to be here, and that's February 3rd. Finally, I just want to let you know that video recording of this terrific conversation with Liz Fowler will be available in about a day or two. It'll be posted right here, but it's also available on your various social media platforms as a podcast, and also as a YouTube video. So I want to once again thank our terrific partner, Scott Kiefer and Blue Cross Blue Shield of Minnesota. Our programs are free and open. If you're interested in joining our donor circle, please get in touch.